This is a quick review about malignant priapism. First of all, priapism is defined as persistent, prolonged and painful erection, which lasts for more than 6 hours and not associated with sexual stimulation. It was first described in the year 1824 and named after the Greek god of fertility, Priapus. There is a wide range of causes. It could be idiopathic. It could be secondary to blood diseases, like sickle cell anemia, leukemia, or lymphoma. It could be secondary to neurological condition, like spinal cord injury, or trauma to perineum or genitalia. Priapism could also be due to iatrogenic causes, like intracavernous injections. It could be secondary to infections like malaria or rabies. The most important cause for us here is priapism, secondary to penile metastasis of malignant tumor. Penile metastasis is an uncommon condition that was first described in 1870. Since then, 460 cases have been described. Its manifestations include indurated nodules, presence of penile mass, diffuse penile swelling, ulceration, or priapism, which is present in 40% of cases. In such a case, it is called malignant priapism. Metastatic tumors of the penis represent evidence of a more widespread malignant disease with a poor prognosis, and the majority of patients die within 1 year. Tumors spread to the penis, either by retrograde venous spread, retrograde lymphatic spread, arterial spread, direct local invasion, or implantation of tumor cells during instrumentation and damage to urethral mucosa. Malignant priapism is defined as persistent, painful, non-sexual erections caused by invasion of malignant cells into cavernosal spaces and their associated venous systems. The term malignant priapism was first used by Peacock in the year 1938, and since then, 88 cases have been reported. It occurred in 40% of cases of tumor penile metastasis. The most common primary tumor sites include urinary bladder, prostate, kidney, GIT, and testicles. Tumor infiltration of the corpora cavernosa leads to stasis and thrombosis of the venous sinuses, which blocks the venous drainage. The remaining patent cavernous sinuses become distended, leading to erection. The infiltration also causes irritation of neural pathways, which causes pain. The arterial supply is usually not affected. Investigations of malignant priapism include core needle biopsy or corporeal aspiration, which can confirm the diagnosis. MRI is a reliable alternative for confirming the diagnosis. It also can assess the extension of the disease. Doppler ultrasound can differentiate between high-flow and low-flow priapism. Management of malignant priapism is usually tailored according to the scenario of the case. Conservative treatment or symptomatic treatment could be a reasonable choice due to short life expectancy of the patients. Excision of corpora could be effective in pain management. Other options include penectomy, radiotherapy, and chemotherapy. This is a case report about a patient that presented recently to the hospital. He was a 64-year-old gentleman that presented with lethargy, weight loss, and generalized bony aches over the last 3 months. He also had constipation for 1 week and a painful erection for 1 month. He was voiding with no problems, did not have hematuria. His rectal examination showed a benign feeling prostate with PSA of 1.4. His S-penis was soft. He had a CT scan that showed enlarged hilar, mediastinal, and para-aortic lymph nodes. It also showed necrotic inguinal lymph nodes, large left adrenal mass, and L3 vertebral body collapse. A biopsy was taken from the necrotic inguinal lymph nodes, and this showed poorly differentiated squamous cell carcinoma. The patient refused any further interventions, and he died 2 weeks later. I hope you found this useful. Please, feel free to send your feedback on my email shown on the screen. Thank you.